not enteral, or bypassing the enteral route, which is the standard, more physiological route of feeding when you take your food through your mouth, going through your GI tract. There are certain situations, and we'll talk about these, where the GI tract is not feasible for provision of nutrition, and thus we had to come up with a solution to provide patients who cannot take anything enterally with nutrition, and hence the thought or the idea of parental nutrition, which is provision of nutrients via parental route through the IV, an IV line, usually through a central line. Again, we'll talk about the details of these. So in the history of total parental nutrition, it started in the 1650s on animal studies where nutrients were infused into animals. In 1911, IV glucose was given post-operatively for nutrition. In 1916, IV fat infusion was introduced. However, it was associated with a lot of complications, and it was dismissed at the time, but then re-explored in the 1950s. In 1969, subclavian vein was used for hyperalimentation, and this is as close as it gets to our current day or modern day total parental nutrition. There are different nomenclature associated with the same thing. By the way, guys, please, if anybody has a question, go ahead and stop me and ask. I don't mind at all. I can see the chat, or maybe if somebody can raise their hands. So for total parental nutrition nomenclature, it's called total nutritional admixture, or TNA. It's called hyperalimentation, and this is the older name for it. It's also called parental nutrition. A lot of people argue parental nutrition over total parental nutrition is that because we are not 100% given all the nutrients that the patients need, and hence the word total is not very accurate, and that's why they advocate the use of parental nutrition over total parental nutrition. But at the end of the day, all of these names are fine. So what's included in that bag? The total parental nutrition bag, or the IV food, contains macronutrients, which are carbohydrates, protein, and fatty acids, as well as micronutrients, which includes the minerals, trace elements, and vitamins. All of these are dispersed in a vehicle of water. Obviously, everything has to be sterile because it's given through the parenteral line directly into the bloodstream, bypassing all protective mechanisms. And this comes with a hefty price tag. Each TPN bag costs about $100 to $150 US per day. When do we use TPN? As I mentioned earlier, the physiological route of providing nutritional support is through the enteral or the GI tract. We use total parental nutrition in patients who are unable to eat or tolerate tube feeding, such as those with paralytic ileus or those with intractable vomiting and or severe diarrhea. We use it for patients who should not eat or use tube feeding, such as those who have intestinal obstruction or fistula. Severe pancreatitis, even though it has become more limited as an indication in more recent years, however, it still remains severe in certain cases. There are times when enteral feeding are unsuccessful. In that case, you cannot leave your patient without any nutritional support. TPN is indicated. And then this is kind of a controversial indication, but there are instances where TPN is given short-term for patients with severe electrolyte imbalances, simply because you're able to replenish several electrolytes at the same time in a TPN solution, which you can't in a regular IV solution. So the rule of thumb, if the gut works, use it. And this saying has been modified to say if the gut works partially, use it partially. So my great emphasis here is that the GI should be my primary route of nutritional support. If I'm unable to provide 100% nutritional support through the GI tract, I will still provide as much as I can and then replenish the rest with total parenteral nutrition. And there are reasons for that. Enteral nutrition is more physiologic and should be the primary route for nutritional support. It provides a trophic effect on the GI tract, and this trophic effect is not only beneficial for the health of the GI system and absorption of nutrients, but also it has an immunological factor in protecting against bacterial translocation. It's also easier, more flexible, and cheaper by TPN. Obviously, this statement can be argued depending on which restaurant you're eating at, but technically speaking, for all normal oral diet is definitely cheaper than parenteral nutrition. It's associated with less mechanical, metabolic, and infectious complications. The TPN can be given either through a central line or a peripheral line. We call it peripheral parenteral nutrition, or PPN. The advantages of giving TPN through a central line is you can provide full support without limitations, especially important in patients who are fluid restricted, no pain or thromboembolism, and can be used long-term. Let me be more clear. So let's start from the very beginning. I have established that my patient requires nutritional support through parenteral route because they're unable to or should not be using the enteral route. So the next step will be deciding whether to give this patient his TPN through a central or a peripheral line. A central line can have an unlimited concentration of nutrients or milliosmoles because of the high flow and the wide lumen of a central line. So you are not limited. You can give a highly concentrated fluid, and that's why it's important, or it's useful in patients who are fluid restricted and cannot be given a large volume of fluids. Also, because the contact time with the TPN and the vein is minimal because of the high flow of blood in the wide veins, there will be no pain or thromboembolism, and that makes it suitable for long-term use. The disadvantages, though, is that you need to have a surgery for line placement, and then there's a high risk of complications because central lines are associated with more complications than peripheral lines. Peripheral lines, on the other hand, are easy to administer. You are limited, however, by the amount of nutrients because you need to maintain your osmolarity to below 800 milliosmol per liter. This cutoff is different between adults and pediatrics. Pediatrics are able to tolerate higher milliosmolarity, however, it's still restricted. And it can only be used short-term because there's a risk of phlebitis and irritation to the vein. Usually we rotate the site every 3 days, and patients who have been sick and have been receiving a lot of medications through their peripheral veins have worse quality veins, so you may need to rotate them less frequently. Now, something very important, a TPN that is prepared for a central line should never be given peripherally. Otherwise, this is what you're going to get. You're going to get severe phlebitis and probably even advanced to necrosis. So what will I take into consideration before deciding if I should give the TPN centrally or peripherally? It depends on the patient's fluid restriction status. It depends on the duration that I expect the patient to require parenteral nutrition. The longer the duration, the better it is to give it through a central line. And it also depends on the quality of the patient's veins. Sometimes patients will require short duration. However, due to the fact that their veins are very poor quality, it's preferred to give it through a central line. So after establishing how am I going to give my TPN and the indication for the TPN, the next step would be determining the nutritional requirements. There are different methodologies for determining nutritional requirements, and these are the same for parenteral versus enteral nutrition. The most agreed upon method is using the Harris-Benedict equation for basal energy expenditure, which is how many calories you need without doing any efforts. And then based on the patient's condition, you will multiply it by either 1.2%, 1.3, so you give 130, 120% of their nutritional requirements, depending on their status and depending on their stress level and all of these other factors. For pediatrics, we use the recommended daily allowances, which are expressed as kilocalorie per kg per day, depending on their age and gender. Next step after establishing the nutritional or the caloric requirements of patients is determining the fluid requirements of patients. There are multiple different calculations to determine the water requirements for adults. Either you do 1500 mL per meter square, 35 mL per kg per day, or 1500 mL for the first 20 kgs, followed by 20 mL per kg over 20. Obviously, these are not fixed because they're affected by fever, GI losses, and other losses, so it needs to be tailored according to each individual patient. So the next step, after determining how much fluid each patient needs, I will determine my macronutrients, the first of which is carbohydrates. In the TPN solution, it is provided as dextrose monohydrates. The main role of it is to provide energy. In patients who are starved, I need to be cautious in providing high dextrose because then patients may develop pre-feeding syndrome. In stock solutions of dextrose are available as 5%, which is D5 water, 10%, 50%, and 70%. So this way, you can prepare a highly concentrated solution in the TPN. Each gram of dextrose provides 3.4 kilocalorie. And to calculate your starting doses, we start with 2 milligram per kg per minute, which is the minimum for brain function because human brain can only utilize dextrose as a source of energy. And so this is the minimum you need to provide your patients, and then you advance it gradually over the course of 3 to 4 days to a maximum of 4. Exceeding that number will lead to complications. Next, macronutrients is the amino acids, which are components of body protein. These are important for wound healing, blood clotting, hepatic and renal function, as well as immunity. The available stock solutions for these are 10 and 15% solutions. In case you're not familiar with the percentage of solutions, that's the number of grams per 100 ml. Each gram of protein provides 4 kilocalories, and the starting dose is 0.5 gram per kg per day, advanced gradually over the course of 3 to 4 days to a maximum of 1.5 to 2 grams per day. Obviously, certain considerations need to be taken in patients who have either renal impairment, hepatic impairment, or other conditions that will require us to limit their intake of amino acids. So those patients are likely to require 1 gram per day or even 0.8 grams per day. However, patients who are growing, younger in age, these will require the higher dosage spectrum. So the target for them will be 2 grams per kg per day. The last macronutrient is fat or lipids. It comes either as long-chain triglycerides, which includes essential fatty acids, linoleic acid, and alpha-linoleic acid, which contains egg yolk, phospholipids, and glycerin. And there is the medium-chain triglycerides, long-chain triglyceride mixtures, which include essential fatty acids, linoleic acid, oleic acid, capric acid, palmitic acid, capric acid, stearic acid, and alpha-linoleic acid, as well as omega-3 fatty acids, DHA and EPA, with egg yolk phospholipids. Lipids are important for membrane synthesis and stabilization. They are a caloric-rich source, which is important, especially in patients with diabetes, where you don't want to provide them with a large dose of carbohydrates. Each gram of lipids provides between 9.5 to 10 kilocalories. The difference, because normal lipids in diet contain 9, but the difference here is because of the emulsifier. The usual adult starting dose is 0.5 grams per kg per day, and this is advanced gradually over the course of 3 days to a maximum of 1.5 gram per kg per day. In really young patients, neonates, for example, they can go up to 2 or even 2.5 grams per kg per day. It's very important to keep in mind that the fat molecule that I infuse is a large size and could trigger an immune response. And hence, I need to be cautious with my infusion rate, not to exceed 0.15 gram per kg per hour to avoid inflammation and immunosuppression. Because if I exceed that rate, I will overwhelm the macrophages in the blood, and then this will lead to negative consequences. These are the macronutrients. Next, I'll be determining the electrolytes that need to be added to the total parental nutrition, starting with sodium. the recommended daily allowances for adults is 70 to 100 milliequivalents per day. Potassium is required for glucocellular utilization, and the recommended daily allowances is 70 to 100 milliequivalents per day. Magnesium is important for cell function, and most adults require 8 to 20 millimoles per day. Calcium is important for nerve conduction, bone mineralization, and the recommended daily allowance is 5 to 7 millimoles per day. And then finally, phosphate is important for energy metabolism, and the recommended daily allowances is 10 to 15 millimoles per day. Now, obviously, these numbers are just their RDAs, and they do not determine how much to give each patient. A thorough history needs to be taken to determine the requirements for each individual patient, as well as their lab tests, which also need to be followed on a daily basis. Trace elements that are provided in the TPN include chromium, copper, manganese, zinc, and selenium. And multivitamins include B complex, which is an important metabolic coenzyme, important for energy transfer to ATP, ascorbic acid, which is important for collagen synthesis, wound healing, vitamin A, which is important for vision, mucus production, and bone growth, vitamin D, which is important for calcium phosphate homeostasis, bone calcification, as well as vitamin K, which is important for prothrombin generation and clotting factors. So after we have determined the components of the TPN, the fluids, the macronutrients, the micronutrients, the next step would be to prepare the TPN. This is done aseptically by pharmacy personnel, and it could either be done manually, meaning I will manually using a syringe, extract the required amounts and infuse them into the TPN bag, versus automated machines that can be fed with the prescription, including the amounts required from each nutrient, and then these are automatically infused into the bag. There are two different ways to prepare a TPN bag. There's something we call 3-in-1 and 2-in-1. The 2-in-1 is when you have the carbohydrates and the amino acids together in one bag, with the fat separate in a different bag. And the 3-in-1 is when you have the lipids included in the same bag with the amino acids and the carbohydrates. There are advantages and disadvantages of each. When you have 3-in-1, it's easier for nursing staff because you can just hang one bag with a single IV access, and then this is given over the course of 24 hours, mostly. However, the only thing with that is that it becomes opaque because the fat is like a milky emulsion solution. So you cannot really visually examine the bag for any particles that may be present. Plus, when you're infusing the fat for 24 hours, this limits your ability to monitor the triglycerides level because it will be infusing. So you have to discontinue the infusion for quite some time and then take a sample to have an accurate triglyceride level. TPN is also available as a pre-mixed commercial solution where you can buy it and just give it to the patient versus customizing your TPN bag and deciding on the exact amount of each nutrient. Obviously, customization allows you to choose exactly how much to give to the patient, whereas you are limited with the fixed concentrations of a pre-mixed TPN bag. On the other hand, the pre-mixed TPN bag is so much easier because it's right there. You don't need to wait for it to be prepared. And then you, again, like we mentioned previously, I need to decide whether I'm giving my TPN peripherally versus centrally, and this will affect how it's prepared and the amount and the concentration of each ingredient in it. So once the TPN bag is prepared and inspected and ensured that it's sterile and free from any particles, the next step will be administration. It's very important to establish and care for the venous access, whether it's central or peripheral. And then I need to decide if I need to give my TPN in a continuous versus a cyclic fashion. A continuous infusion is giving it at a constant rate over 24 hours, whereas cyclic is infusing TPN over a few hours, for example, 10 to 16 hours. The standard administration technique for TPN in hospitalized patients is a constant 24-hour administration. However, cyclic administration is beneficial when you have other medications that are incompatible. So you need to stop the TPN infusion, give the patient the medications, and then resume the TPN. There are patients who require TPN for long-term, or even patients taking it at home. Those patients will benefit from wire-free time, where you give them cyclic to allow them greater mobility so that they are not hooked to it the whole time. I need to ensure when I determine my rate of infusion is the maximum fluid per hour, how much is the maximum that the patient can tolerate. I need to keep in mind how much electrolytes I have in my solution, because electrolytes as well have a maximum rate of infusion. There has been internationally several incidents of patient death because of exceeding the maximum infusion rate of potassium, especially. So this is very important and needs to be taken into consideration. I need to also ensure the compatibility of co-administered medications. If you look at this, this is an IV lumen that has two ports. We call this a Y site. You can co-administer two medications together. So you need to make sure before giving, if a patient has a TPN running, for example, through this lumen, we need to make sure before administering any other medication through the other lumen that they are compatible through the Y site. Usually pharmacy will provide you with this information. So monitoring is very important. Before starting my TPN, I need to have a baseline nutritional assessment using anthropometric measures, including weight, as well as plasma proteins, including albumin and pre-albumin. I need to ensure catheter placement. Definitely never start a TPN until you have an X-ray confirming the location of your central line to make sure that it's actually a central line. I need to have a baseline lab tests, including electrolytes, blood and urine glucose, as well as liver function tests. And then during the administration, vital signs are important to detect early signs of infection. Catheter site needs to be examined daily for infection. We need to check pump infusion rates because errors can lead to negative consequences. Labs need to be done daily. And once a patient is stabilized, especially in the early period, because you're building up your nutritional requirements, but then as the patient is more stable, you can do the labs 2 to 3 times per week, or sometimes even weekly or more frequently in patients on long-term TPN who are stable. I need to monitor weight changes because this will tell me how well I'm doing in terms of nutritional support. Fluid intake and output is also very important. For the complications related to TPN, I have catheter-related infection complications, which include infections or exclusions. Hepatic disease has been reported frequently with TPN, especially long-term TPN and TPN consisting of high concentration of glucose or dextrose, which is why we limit it. It can cause either steatosis or fatty liver or cholestasis. The solution for hepatic disease with TPN is either to switch the patient to cyclic TPN, which gives the liver a break from processing all of these nutrients, and or reducing the dextrose content of the TPN. For the GI complications, gastroparesis and intestinal hypoplasia, and these two may not be a direct result from TPN administration itself, but rather because patients who are on TPN generally tend to be NPO, and that's why we try to advise against keeping patients NPO whenever possible. Metabolic bone disease can occur mainly because of contamination of some of the TPN components with aluminum, which has improved a lot in the more recent years, but it can cause back pain and fractures, especially in patients who have renal impairment. They have the greater tendency to develop aluminum toxicity as they're unable to clear it as efficiently. One of the major complications of TPN, which occurs mostly in patients who are severely malnourished, is refeeding syndrome. What happens is that when you provide the patient with rapid nutrient support without adequate electrolyte supplementation, what happens is that you will have severely low potassium and magnesium, leading to arrhythmia or respiratory failure or death. This can occur even when you look at the patient's baseline labs and you see their potassium phosphate is normal. However, this could be misleading because potassium and phosphate are mainly intracellular electrolytes and not extracellular. So the body will maintain normal potassium and phosphate levels in the blood, even if the total body stores of these electrolytes is low, which occurs in periods of prolonged starvation. That's why history is very important. You need to make sure that the patients are not severely malnourished, which can be evident by severe weight loss, history of anorexia, prolonged anorexia, severe history of vomiting or diarrhea. Because what happens then is that when you provide all of these nutrients, the body is so hungry to utilize them, so it will pull all of these electrolytes from the blood and take it into the cell where it belongs, because there isn't enough inside the cells. And this will cause a severe drop in potassium phosphate in the blood and magnesium, leading to cardiac arrhythmia and or death. So it's very important to take note of that. For sepsis, the main reasons why it occurs with TPN is keeping the patient NPO, because then you have atrophy and the villi and microvilli in your GI, leading to bacterial translocation, where the bacteria will move from the intestine into the bloodstream. It could be CVC related, central venous catheter, if it's not cared for properly. It could be from the TPN solution, even though it's prepared under a strict aseptic technique. Sometimes mistakes happen and it could be a source of infection. Having a patient in constant hyperglycemia also can lead to sepsis, as well as using large IV fat doses and neutropenia. To prevent it, proper CVC dressing should be applied. Peripherally inserted central catheter is preferred. That's when you put the central catheter through a peripheral vein and then advance it into a central location. So you have the advantages of both. Giving the patients early enteral feeding and preventing persistent hyperglycemia by frequent monitoring and treatment. That's all I have for TPN. Does anybody have any questions? Okay, I hope it was clear to all of you. I just want to let you know that I don't require you to memorize doses, but I like you to understand what's most important to me is that you understand the basic principles of when a TPN is indicated, when to monitor it, and all of these things. However, I will not be asking you about numbers or anything of that sort. Any other comments before we conclude?
Thank you, Doctor.
All right, thank you very much and have a great day. Feel free to contact me by email if you have any questions or anything in the future. Thank you.